Right, so let's start. Welcome everyone to session 8 for morphology. This is for both FRC Path UK exam candidates and for the lab staff. Let's start with the first case. I would need 5 volunteers for the case description. They can be both clinical hematologist or lab hematologist, no issue. Right, so this is the first case. This is a GP blood sample who has been sent to your hospital for assessment. The patient went to the GP because of um, continuous and ongoing fatigue and tiredness. He is 80-year-old with comorbidities of ischemic heart attack 5 years ago, and he has uh, chronic renal failure as well. So 80-year-old, comorbidities of cardiomyopathy and uh, nephropathy. He has ongoing tiredness, and this is the blood film of the patient. Right. So I would need one volunteer first to comment and report the blood film.
So there is a increase in lymphocytes.
Okay. So you are Dr. Saima Iram or Dr. Fatma? Who is speaking?
Saima
Saima.
Iram.
Right. So this is power 10. I will go through the film to give you an overview, and then I will move to power 50, which is an oil lens with me, and then you can comment or report the blood film. Right?
Sir, there is rouleau formation, and as these lymphocytes appear to have their nucleus pushed to one side, so maybe it's plasma cells, these are all.
Now power 50. So this is the cell.
This appears to be lymphoplasmacytide cell.
See some more, and then you can report the blood film for the GP.
I can appreciate the hairy projections along the cytoplasm, circumferential. Am I right?
There is some projections from this cell. Okay. So these are three more cells.
Right. These are lymphocytes with circumferential projections of cytoplasm.
Sir,
This is appearing as
Sir, the cells are having eccentric nuclei and there is perinuclear halo and intensely basophilic cytoplasm. And I would go with the probability of plasma cells. And RBCs are showing Role formation.
Okay, right. So, are you a hematologist or a lab staff?
Sir, hematologist, Dr.
Okay,
Habiba.
right. So now you are sitting in the FRC Part 2 exam. The first question for you would be report this blood film. It's a 6 marks question.
Okay. Sir, this is the blood film of this is a peripheral blood smear, which shows increased white blood cells count, and majority of them are plasma cells. And also appreciated a few neutrophils and a monocyte. And red blood cells are normocytic nomochromic and is showing Roulet formation, and platelet count is also adequate. The peripheral films is suggestive of plasma cell leukemia, and bone marrow aspiration and refined biopsy uh, is advised for further confirmation of diagnosis, and for cytogenetics and fish. In cytogenetics, we would go for three translocations of 414, 1416, and 1420 translocations. Also, I will go for the workup of serum protein electrophoresis and immunofixation.
So
And
the question was to report the blood film. You have only 9 minutes in the exam to attempt this question, which will include report the blood film and few other parts as well.
oh,
So,
okay, sir.
so so the dominant feature is increased in plasma cell in this patient. So the blood film shows leukocytosis or increased number of plasma cells with rouleau formation. The red blood cell morphology is normal with normal platelet count as well. There is no platelet clumps. The blood film is most likely consistent with,
Plasma cell leukemia,
you are saying plasma cell leukemia on the basis of,
sir, on the basis of plasma cell count, if
okay.
the yeah.
So the blood film is most likely consistent with plasma cell dyscrasias, likely plasma cell leukemia based on the plasma cells present in the peripheral blood. This patient needs further investigation like blood for flow cytometry, um, and bone marrow aspiration and refined biopsy. This patient need to be assessed urgently by a hematologist. So this was the report that you will mention in the exam. You comment on the blood cells. You commented on the your impression, and you give some plan as well. That will complete your report of the blood film.
So, what about the projections around the cytoplasm? Do we see them in plasma cells as well?
Yeah, so plasma cells, lymphoplasmacytic cells, hairy cells, um, and even the blebby cells of the TPLL, they are all known to have projections. But these cells are characteristics plasma cells because they have um, this whitening here.
Perinuclear halo.
Yes, whitening here, which is the Golgi zone, very basophilic cytoplasm, and nucleus is usually to one side. But there may be variation in the plasma cells morphology as well. Some of the um, nucleus may be in the center, not towards one side. but most of the plasma cells here in this film are having halos, basophilic cytoplasm, and the nucleus is toward one side. So these are the features of dysplastic plasma cell. Like this one has a central nucleus, but there is still a halo present over here. The scenario, think about the scenario as well. The scenario does not go with hairy cell leukemia. The hairy cell leukemia usually has pancytopenia features.
Sir,
Right,
there
sir.
is one question.
Mhm.
Um, I have one question. That when we see this plasma cell dyscrasia on peripheral smear, and the most likely or most suggestive diagnosis is plasma cell leukemia, do we go for serum protein electrophoresis and beta 2 microglobulin,
If
uh,
if they ask you
or
in
we
the next
don't?
if they ask you in the next
Uh,
question what investigations are required, then you have to mention uh, serum
okay,
electrophoresis as
sir.
well.
Thank you, sir.
And secondly, the examiners have a
Right.
key. Examiners have a key according to which you have to answer the question. Now, this patient has Howell Jolly here as well. You have to
Yeah.
mention Howell Jolly in your answer as well. Right. So you have
Yes.
reported the blood film. The next question is, what are the prognostic markers in a patient with plasma cell dyscrasia?
So prognostic markers include serum LDH, beta 2 microglobulins, and cytogenetics,
And
um, and and serum albumin as well.
Albumin as well.
and
And um, uh, albumin and um,
plasma cell percentage. If it is more than 5%, you call it as plasma cell leukemia, and it is high risk multiple. It is called high risk multiple myeloma as well, and its treatment is a bit different. But most of the patients are treated according to the same line of therapy as multiple myeloma. But there is a new guideline regarding plasma cell leukemia or high risk multiple myeloma in 2024. They were published in July 2024, and they have um, suggested some new regimens to treat plasma cell leukemia. If you have heard about Optimum study or Concept study, they have suggestion of different quadruplet regimens for plasma cell leukemia, but we are not currently using it because they are not NICE approved. We are still um, using multiple myeloma guidelines for the treatment, transplant eligible or ineligible, or um the DT paste therapy for plasma cell leukemia. Now, next question is, what is the expected flow cytometry in this patient?
Sir, these cells would be CD38 positive, CD138 positive, and CD19 negative, and CD56 might be positive as well.
Why CD56 will be positive here?
Site will
Sir,
be lost.
aberrant expression.
CD56 is an adhesion molecule. If it is
Yeah.
negative, it will allow the plasma cells to come into the peripheral blood. If it is positive, the plasma cells will stay inside the bone marrow. That's why in multiple myeloma, you do not see many plasma cells in the peripheral blood, but in plasma cell leukemia, you do see plasma cells in the peripheral blood as this case. So so CD56 is negative in plasma cell leukemia. It is positive in multiple myeloma.
Okay, sir. Thank you, sir.
Right. And do you think this patient is transplant eligible or transplant not eligible?
Sir, the patient is an elderly and most probably he would be having comorbidities.
He has
So,
comorbidities. So do
yeah.
not say in the exam most commonly he would have comorbidities. It has a negative impression. They have mentioned in a scenario that the patient has cardiomyopathy and nephropathy,
Hmm.
and he is
So,
80 years old.
so keeping in view the comorbidities and his age, he is transplant ineligible.
Yeah, so you will select a therapy for him in the category of transplant non-eligible patient. Right. So plasma cell leukemia is usually a short case in the exam, but it can come as a long case in exam as well. So be ready for that because it has new guidelines. So it can appear in both part one and part two.
Sir, I want to ask a question. How often you use CAR T cell therapy for multiple myeloma? Is it approved or not approved yet in UK?
Um, it it is approved, but it is usually an MDT decision after patient assessment.
Okay, sir. Thank you.
But it is not first line. Right. Right. So this is the second case. This is a 52-year-old man who is very unwell, um, presented to emergency department with uh, worsening fatigue. On examination, he has lymphadenopathy and abdominal discomfort as well, which is because of the splenomegaly. He has lost 10 kg of weight in the last 6 months, and he is short of breath as well. Chest X-ray shows pleural effusion. The full blood count shows hemoglobin of 98, white cell count of 58, and platelet count of 130. The biomedical scientist is concerned that this can be a leukemia. Any volunteer for this case?
Um, Sir, can you give me a a high power view as well? I want to
Okay,
see the morphology of white cells.
okay.
Okay.
Right. So I will move it slowly.
Okay. Sir, this is a peripheral smear of a patient showing normocytic normochromic red blood cells, and there is sir
Mm-hmm.
okay. Sir, there is marked leukocytosis having atypical lymphoid cells with cleaved nuclei, cleaved or clefted, you can say, um, clefted nuclei, and smudging is also seen, and some of the cells are very bizarre shaped, and also we can appreciate the presence of nucleated red blood cells, and here, mm, yeah, it might be a follicular lymphoma, or no, that is too early to say. It might be some lymphoproliferative disorder,
I want
or
you to I want you to report the blood film for the exam purpose.
okay, okay. Um, Sir, the peripheral smear shows normocytic normochromic red blood cells, and the white blood cells are increased, and there are also NRBCs are also seen, and these uh, the white blood cells, they show the clefted nuclei, and smudge cells are also seen, and some the atypical white blood cells are medium to large size, having open nuclear chromatin and prominent nuclei, which we are probably the blast cells, and I also appreciated a few eosinophils as well.
What is your impression?
Um, so my impression is of some lymphoproliferative disorder,
Oh,
and I would recommend flow cytometry
mm-hmm.
and bone marrow aspiration and biopsy.
Right.
And
Can I
and
have a
yeah,
go again?
and yeah, so I will also go for corrected white cell count, because I have seen many NRBCs there, nucleated red cells.
Oh.
Can I have a
Anyone?
go as well, Amir?
Yes. Answer the question. Report the blood
Yeah.
film, please.
Yeah. So the white blood cell shows predominantly lymphoid cells with monomorphic appearance, with some of the lymphocytes showing lymphocytes, clefted lymphocytes. There is presence of nucleated red blood cells. The red cells are appearing. There is some degree of an anisocytosis. At least that's what I am getting. Occasional, I can see a few spherocytes and some rouleau formation. At least from the screen, I can see there are a few rouleau formation. Platelets are reduced in number, consistent with count. Impression, I would say the blood film is suggestive of a lymphoproliferative disorder, would suggest urgent hematology referral, further investigations, which would include peripheral blood for flow cytometry, bone marrow biopsy, and further investigations to rule out further investigations of the CT scans. That's what I would
Oh,
say. I forgot to mention smudge cells in between. Apologies.
yeah. So the blood film. shows leukocytosis because this is the dominant feature. Always mention dominant feature first. Some of the white cells are small to intermediate size with mature chromatin having a deep cleft. Some of them are large with a prominent nucleoli. Previously, they used to be called as centroblast, but that category has been removed after WHO 2022. The red blood cells shows mild degree of anocytosis with few relo formation. The platelet count is decreased, but no clump seen. The blood film is consistent with lymphoproliferative disorder. The patient needs further investigation like flow cytometry, bone marrow biopsy due to cytopenias, and a CT imaging for any lymph node biopsy if present. So that would complete um, your report for 6 marks. Obviously, you cannot make a diagnosis on the basis of blood film. Uh, they would give you some flow to you, or if the diagnosis is obvious, like in previous case, then they would ask you what is the expected flow cytometry. So the flow cytometry of this patient comes out to be CD5 negative, 43 negative, 19 positive, 20 positive, and immunohistochemistry shows BCL2 positive as well. So what are your thoughts about the diagnosis?
Can you please repeat the flow cytometries?
CD5 positive, sorry, CD5 negative, 43 negative, 19 positive, 20 positive, BCL2 positive, and CD10 positive.
It can be
Sir, this is follicular, consistent with follicular lymphoma.
Okay. So the flow
yes,
is
sir.
consistent with follicular lymphoma. What is the final diagnosis?
Follicular lymphoma.
In leukemic phase.
In leukemic phase. So this is
Follicular
the
lymphoma / leukemia.
yeah. So do not confuse follicular lymphoma in leukemic phase with high-grade lymphoma because the high-grade lymphoma has a separate morphology as compared to follicular lymphoma. If it was DLBCL, you will see a lot of big cells with vacuoles in it. We had seen DLBCL blood film before. Right. So the final diagnosis is follicular lymphoma in acute phase. These small to intermediate size lymphocytes, they are the features of follicular lymphoma, and you can see this cleft, which is present from one end to another end. This is the feature of follicular lymphoma. Right. Um, would
Dr.
you
Amit,
treat? Yes.
sorry, I'm interrupting you. As of first, I am saying there is RBC inclusion. Are these inclusion or artifacts or platelets? I mean, are these Howell-Jolly bodies inside the RBC? There is small dot near the
This one is a whole jolly, and this one. Because
yes.
we mentioned in a scenario, patient has abdominal discomfort with splenomegaly. So he must have hyposplenism. So that can lead to Howell-Jolly formation.
And we
Right. So
have
the
to
last,
mention
yes, you have to mention all the findings that is present in the blood film, uh, because the person who checks the paper, your written paper, may not be a clinical hematologist or may not be a morphologist. He has only key which he has to see, like whether this candidate has mentioned Howell Jody, yes, 1 mark. NRBC mention, yes, 1 mark. Leukocytosis with cleft mention, yes, 1 mark. So you have to mention everything uh, in the in your answer that is present in the blood film. Like in the previous session, we had a sickle cell crisis blood film, and the question was name six findings in this blood film.
Mm.
It means there are six findings in this blood film. Right. So the last question for this short case would be, uh, would you treat this patient?
Yes, we would treat this patient because he has entered the leukemic phase.
Hmm. He has cytopenias and he has pleural effusions as well.
Yes.
And you will be doing imaging for this patient. In follicular lymphoma, we usually worry for compression of any nerves or arteries uh, because the follicular lymphoma has a tendency to be present around paratrabecular lymph nodes as well, where they usually press the um, nerves and arteries or veins. So you may be seeing patient in your hospital where the disease burden is less, but they have some lymph node somewhere in the body which is compromising other structures. That's why we decide to treat follicular lymphoma as well. Otherwise, if they are asymptomatic but diagnosed as follicular lymphoma, they are usually on watch and wait list. And what is the criteria, name of the criteria that is used to decide whether the patient needs treatment or not?
Fifthly,
Flippy
Fibrin is,
to
Fibrin
flippy
is
to
the prognostic score. It is the GELF criteria that is
Get
mentioned
criteria.
in the BSH guidelines, which you use to
uh,
decide whether the patient needs treatment or not.
sir, can you please repeat the name?
GELF, GELF, GELF.
Gelf. Okay, sir. Right. Thank you.
So follicular lymphoma can be a short case in the exam, or it can be a long case in the exam as well, where follicular lymphoma blood film would be given, and then the patient would present again after a few months with cytopenias, and then the bone marrow trephine would be given to you. The trephine of follicular lymphoma has a specific feature of peritrabecular infiltration, and later in the question they would ask you that this patient has now converted to um, high-grade lymphoma. So follicular lymphoma is important for both uh, short case of morphology and long case of morphology. Right. The third case. So this is a GP blood sample. Refer to the tertiary hospital where you are working because of eosinophilia. The patient full blood count shows hemoglobin of 110, white cell count of 11, but the eosinophil count is 3 and platelet count is 190. So who wants to have a go? Anyone from clinical hematology background or from um,
Mm.
non-hematology? Mary, yes, Mary.
Hey, Emma. Um,
Uh,
so I think with an eosinophilia film, I'd want to look around on the lowest power possible for a while to look for parasites first.
Okay, right. So this is power 4, and I will move around the blood film to see if there is any parasite or not. So whenever you face eosinophilia in the exam, always go to power 4 to see for any um, parasite.
Oh, there we are.
Yeah,
So we've
because
got
this is,
a
because
few
this is
worms.
because this is a Nicholas film. They are very generous to give you
Mm.
a lot of parasites, but in an exam you may struggle to find one. So better have a good look of the center of the sides of the slides in the exam. So this is the parasite. I will make it to 10 now to see further features of this parasite. So this is power 10.
So we've
And
got a sheathed worm, or microfilaria. Is that I always get confused about that. Sorry. Which has got the presence. You can see the sheath extending beyond the head end. So I just want to see whether the nuclei go all the way to the end of the tail.
yeah, so now it should be clear.
Yeah. So you can see the sheath. It doesn't look like the nuclei go all the way to the end of the tail, which would be most in keeping with a Wucheria.
Okay, so let's see another um, worm, which if there is any a straight one,
Mm-hmm.
that would be helpful.
Is this can I just ask, is this a Geim sustain or is this a normal
It's a normal stain.
stain? That's what I thought so. So it should be bluer if it's Geim, sir.
Yeah, maybe this one.
Oh, so in this one it looks like the nuclei do extend all the way to the tip of the tail.
Yes, now hopefully we would be
Yeah.
able to.
So that would be in keeping with the lower.
Yeah,
Does.
yeah, so this is the sheet, is the head end, this is again the sheet, and this is the tail end. They are coming in a line here. Okay, so how would you report this film for the exam purpose?
So I'd report it as the dominant findings are the presence of microfilariae, which are sheathed and demonstrate nuclei to the tip of the tail in keeping with lower. And then I would comment on red cell morphology being unremarkable, as there are increased numbers of morphologically normal eosinophils, mature neutrophils, and lymphocytes, which show no significant abnormality, and adequate numbers of platelets.
Yes, I'm searching for any flat one. The flat one are usually better. Yeah, this is the one.
Oh yeah, there's don't normally get the sheath that well stained.
Um, as I mentioned, this is a Nicholas film,
Yeah.
so you will see a lot of worms in the Nicholas films, and also they will be looking better as well as compared to the exam one.
Yeah.
Our exam has only one worm per slide.
They're very stingy with their worms in the exam.
Right. So, for the purpose of audience, do you know any formula that you have remembered to differentiate between different worms? Wuchereria, lower, or Bruga malai?
So the first thing is to look and see whether they are sheathed or unsheathed,
Mm-hmm.
and then the distribution of the nuclei. So lower is the one that classically has the nuclei all the way to the very end of the tail, whereas the Wuchereria, I think they don't normally go all the way down. But the Wuchereria is also sheathed, and then I think the Manzanellas are not sheathed. Is that correct?
Yes. And another one is Bruga malai. I don't know whether I'm pronouncing the name correctly or not, but they are also sheath, but they have only two nuclei at the end of the tail.
Yeah.
So I had remembered like that Wuchereria starting from W, Vemti is empty, Wuchereria tail is empty, Bruga
Mhm.
malaya has binuclei at the tail of the tip of the end, and lower goes to the lower end. So nuclei
Mhm.
extend to the tail. Like that, I had remembered for the exam purpose. And Manzanella has no sheath.
Yeah.
Um, and do you remember any treatment drug for this lower?
You can either use mebendazole or albendazole.
Uh, the book has mentioned DEC, diethyl carbamazine. And other sessions and courses also mention DEC for the treatment of lower or loasis. So it will be either a eosinophilia case in the exam or someone who has recently traveled to Africa and came with a red swollen eye, which is called Calabar eye or Calabar swelling. But in case of eosinophilia, always go to power 4 to find out if there is any worm or not. Look thoroughly because we suffered in the recent exam because of this. Right. So this was the third case. Thank you, Mary.
Thank you.
So this is the fourth case. This is again a GP blood sample of a 5-year-old boy who recently emigrated to UK from an Asian country. The full blood count shows hemoglobin of 128, white cell count of 8, and platelet count of 180. Any volunteer to comment on the blood film?
Sorry, sir. Can you please repeat the presenting complaint of this patient?
Yeah.
Um,
So this is a GP blood sample of a 5-year-old boy who has recently emigrated from an Asian country. The full blood count shows white cell count of 8, hemoglobin of 128, and platelet of 180.
Okay.
So this is
Sir,
this is our 10 to give a general overview. So 50.
There is marked elliptocytosis seen in the red blood cells.
Okay. So for the purpose of audience, why this is not a boat-shaped cell or why this is not a sickle cell?
The sickle cells will be having both tapering ends, and these are rounded on sides.
And
Sir, history of the patient is not suggestive of
so
sickle cell or shape you're talking about.
the elliptocyte still carry halo. The red cell halo is still present in them, and they are elongated or oval shaped, but they carries halo in themselves. The sickle cells are haloless. They don't have any halo in the in the sickle cell, and their ends are sharp. So this is the difference between elongated elliptocyte and boat-shaped cell of sickle cell disease or sickle cell itself. Halo and the edges of the cell. All right. So I want you to report this film for the exam purpose. 6 marks. Anyone?
Yes, I can try.
Yes, go ahead, please.
So the peripheral smear shows RBC. There is marked anisopyclocytosis, but majority of the red cells are elliptocytes in shape. And as far as I'm seeing there is no inclusion in the red cells.
No? Sorry, what?
Red cell inclusions inside the red
Okay.
cells, and platelets are adequate. And there is a few schistocytes as well, but they are few in the background. And majority of the population, yeah, this is Howell Jolly body.
Yeah.
Okay.
So you
And
have to write all the findings for the exam. Do not ignore any finding.
okay.
Yeah.
And platelets are adequate in the background, and neutrophils are preserved.
Okay.
So the peripheral smear consistent with um, any hereditary membranopathy, most likely hereditary lactocytosis.
Do not say hereditary elliptocytosis.
Okay.
Only elliptocytosis because you do not know the history of the patient. This is only blood film in front of you. So do not
Okay.
make such mistakes in the exam. So
Okay.
this is the only blood film. That this blood film shows red cell enocytosis. Most of them are um,
Electrocyte.
elongated to oval-shaped electrocytes. If you want to explain, we'll just add one more line that the elliptocyte is carrying a red cell halo. The ends are not sharp, just for the purpose of other audience as well. I'm mentioning this. The platelet counts are fine, white cell count are normal, most likely uh, associated with uh, elliptocytosis or membranopathy like elliptocytosis. The patient needs further investigations to rule out the cause of elliptocytosis because the elliptocytosis can be because of multiple causes.
Okay.
It can be hereditary, it can be iron deficiency anemia, it can be myelodysplasia or hematinic deficiency even. They can lead to uh, elliptocytosis. So the next question would be, what is the defect in hereditary elliptocytosis and what is the inheritance?
Inheritance, I'm not confirmed. Maybe autosomal recessive.
It's
They would
autosomal dominant.
autosomal dominant. And where is the defect in the membrane in hereditary elliptocytosis?
No, I don't remember.
Sir,
Band 3 protein.
dimerization defect of spectrin A and alpha and beta spectrin.
Yes, you can mention spectrin alpha, beta, and protein 4.1 defect in the uh, hereditary elliptocytosis. The hereditary spherocytosis carries protein 4.2 defect, and this one carries protein 4.1 defect. This is for part one question, but they can ask in the part two as well as a 1 mark or 2 mark question in short case.
Okay.
All right. What is the management of this patient if it comes out as hereditary elliptocytosis?
So supportive treatment, like, but here's HP is 12, I think.
Sorry?
No treatment is
I think I think no treatment is there because hemoglobin is normal. Hemoglobin is 12, as far as
Yeah.
I remember.
Yeah. So if the patient is asymptomatic, no treatment is required for hereditary elliptocytosis. But if he becomes anemic, then he would need folic acid replacement
Got it.
for that.
Mm.
Yes. What is the result of EMA in hereditary elliptocytosis? The last question.
You are talking about fluorescence?
EMA, yes.
No fluorescence?
Eosin, maleimide assay.
EMA?
Yes.
No, I.
Eosin, maleimide binding assay or binding test.
Sir, there is decreased EMA binding.
So EMA remains normal in hereditary elliptocytosis. It is low in hereditary spherocytosis.
Okay.
Yeah. So remember this if they ask you in the exam, both for part one and part two. All right.
Thank you.
So blood, any type of blood films can come in the exam. You can have iron deficiency anemia. You can have B12 deficiency blood film in the exam as well. In short cases, we had these type of things in the recent exam. So the films may look very easy to you, like this is electrocytosis. Okay, fine. But the trick is in gaining marks. In such cases, you should at least get 8 out of 10 marks or 9 out of 10 marks. Each number, each mark in the exam matter. if you talk to your or two colleagues, they would tell you the importance of 0.5 to 1 mark. So please do not ignore anything in the blood film. Even if you know that you are good in morphology, practice them frequently with yourself, with your colleagues, with your senior in the hospital, so that they are on your fingertip and you should know what is expected in a blood film. So this is the last blood film of the day. Ignore this stuff. This is just a particle in oil which is moving. This is not a live bacteria or virus, anything. Right. So this is a 29-year-old patient who presented to GP because of the lower respiratory tract infection. So he was given levofloxacin tablets or antibiotics to take that. On the next day, he became very short of breath, pale, and on repeat blood test, he was found to be anemic. Hemoglobin dropped from 130 to 85. The biomedical scientist alerted you because he thinks that this patient has a TTP. He has noticed few schistocytes in that blood film. Right. So anyone want to go with this film, please?
Seems like it has spherocytosis.
Okay. Right, so this is power 10. Sorry, who was that? Do you want to comment on the blood film and report the blood film? Anyone?
I can try if no one other won't.
Okay, go ahead. Right. So this is power 50 now. You heard the story. A young man who has taken levofloxacin for lower respiratory tract infection presented to ED next day because of shortness of breath, and the biomedical scientist alerted you for schistocyte presence of schistocytes. So this is the blood film.
Well, I can see spherocytes as well as necrocytosis in the red cells, but there's also a bite cell is there. Yeah, few cells are looking like, yeah, this is a bite cell, blister and bite cells,
Mm-hmm.
and
यार आपने
maybe
पानी है पानी में रहता है फिर भर गई मेरा मुझे लगता है फिर ये ना
and the platelet count are adequate in the background, and there is maybe Howell Jolly body in the
Okay. Yes. Some of the red cell has Howell-Jolly bodies.
dead bodies. Okay, neutrophils are preserved, and a platelet count are adequate in the smear. So the peripheral blood film consistent with some enzymopathy disorder, or maybe that is
Enzymopathy on the
yeah,
basis of blood film.
on the basis of blood film and history.
Yeah.
So
So we can say oxidative stress.
So the patient has oxidative stress because he has taken levofloxacin and then he developed hemolysis.
hmm.
So
So
there is also polychromasia. Some
yeah,
polychromatophilic cells are seen.
yes, and even the neutrophils are hypergranular as well. So how would you report this blood film for the exam purpose? 6 marks.
I would so there is hypersegmentation as well in the neutrophils with
Yes, these
hypergranularity.
these few neutrophils shows very high hypersegmentation.
Toxic granulations and cytoplasmic maculations are also appreciated.
Mhm. So how would you report that film for the exam purpose?
So the peripheral blood consistent with, as Dr. Habiba said, oxidative stress, under the oxidative stress, or maybe most secondary to the enzymopathy. So I would go for further investigation or refer to the hematologist.
So why are you saying enzymopathy again and again when
I
you
don't
have
know
no,
because he's a
when-
boy and
because hemolysis can be uh, related to B12 deficiency as well. This
yeah.
patient has hypersegmented neutrophils, so there can be multiple causes of hemolysis in this patient. So the
But
blood
why there?
blood so the blood
But why?
film. Mhm.
Mhm. But why there are bite and blister cells and why there is whole jolly bodies inside the cell? But this is not a feature of megaloblastic anemia.
Yeah, so there can be dual pathology as well.
The other thing, actually, this is an acute drop in hemoglobin from
Ah,
13 to 8. This is actually hemolytic process after
yeah.
oxidative stress. And these bite and blister cells are very obvious
Hmm.
in the peripheral field. This is my input, please. Although there are hypersegmented neutrophils are also there, polychromatic cells, bite and blister cells are very obvious in the peripheral field. That's the reason I think maybe more likely it is hemolytic process due to oxidative stress. And enzymopathy is one of the cause.
Underlying cause. Underlying cause. Yes.
Yes. So
Can I try and report the film?
yeah,
It might
go
not
ahead.
be amazing, but I think I would term it as um, prominent anisopoikilocytosis with prominent bite and blister cells, mild polychromasia, Havel jolly bodies, and target cells are also visible. Neutrophils show toxic segmentation, toxic granulation, and hypersegmentation. Vaculation is also seen. Uh, I actually don't remember what the platelet count was, but lightly reduced. And I would say differentials would be oxidative stress leading to oxidative hemolysis, um, and a possibility of a hematinic deficiency as well.
Hmm. And what would you suggest?
Um, I would suggest urgent hematology opinion, not urgent, but like discuss with hematology.
You are the hematologist, right?
Yes.
Okay.
Um, so a complete hemolysis screen, um, and checking for hematinics, B12 folate, And I would say do a G6PD assay, but once the patient's out of the acute phase.
Yes. So, as you mentioned, uh, all the features of the blood film you have to mention. This blood film is an RDA blood film to come in the exam as mention 6 features in this blood film. So this patient has all the features of hemolysis, and it has white cells, whole jelly bodies, spherocytes, polychromatic cells, histiocytes, um, hypersegmented neutrophils, and the few target cells and granulated neutrophils as well. Most likely consisted with hemolysis secondary to oxidative stress and hematinic deficiency. The patient needs um, uh, blood for hematinics and stopping the precipitating factor, if any, which is levofloxacin in this case. You can mention G6PD as well, but we all know that you cannot check G6PD in acute hemolysis. That should be done once the acute hemolysis is over. And if the patient has blood transfusion, then you have to send blood for PCR or Sanger sequencing if indicated. Otherwise, you have to wait for 3 months. Right. So now the next question would be, um, what are the causes of false negative, or what are the conditions that interfere with G6PD assays?
These can be pre-analytic and analytic causes
Mhm.
and type of screening assay, temperature. Uh, I mean, it depends upon the screening type of uh, assay. So pre-analytic, like hemolysis and
So if there is polychromasia, reticulocytosis,
hmm,
reticulocytes
no,
has a lot of G6P D enzyme. You get false negative result.
hmm.
If there
Normal
is,
for normal G6PD levels during acute hemolysis
Sir,
because
also recent transfusion.
yes, if you have done blood transfusion for your patient, that would affect your G6PD testing as well. If you have um, if the patient is grossly anemic, or if because of the infection there is significant leukocytosis, then your results would be not normal. These 4 factors interfere with G6PD testing. Right. Please name the G6PD assays for male and female patients. 2 marks. They are given in the guideline. There is a figure in the guidelines in the BSI which has mentioned G6PD assay testing for male and female patient. Although it is excellent, but you can get very rarely G6PD deficiency in female as well.
Well, female
Sir,
needs.
for the
Hmm.
yeah, continue, Dr. Sindhu.
For female needs a quantitative assay is a confirmatory assay because screening assay may produce false negative,
Hmm.
and while we can go for the screening assay or qualitative screening test for the male, like fluorescence spot and dye decolorization test for the male.
Mhm. And for the female are the quantitative assays, which are called Glock-Maglin tests
Huh.
or one substrate assay. If they are equivocal, then you go for cytochrome test. There is a figure given in the basic guidelines in G6PD guidelines. Uh, if you remember the names, that is fine. They can ask you um, in the short case in morphology, so you should not lose these marks.
Okay.
All right. So this was the end of morphology session 8. We will see you again next week. These sessions are free, but if you want to donate, you can donate either on this account or in this account, or I will share a coffee link in the group. You can donate over there. Please share our subscribe and share our channel. Thank you and have a nice Sunday.
Thank you.
Sir, I have a question. That what is the final time for the